Good morning, Chairman.
Good morning, Trina, and welcome to everyone participating in and listening to this meeting. Can I now ask for Trina Cope to confirm the attendance of committee members?
Good morning, members. So prior to the start of the agenda, can I please ask you to confirm your presence when your name is called? Councillor Carl Macy.
Present.
Councillor Chris Brewis.
Present.
Councillor Bill Bilton.
Present.
Councillor Matthew Fido.
Present.
Councillor Mrs. Lucille Higgs.
Present.
Thank you. Councillor Mrs. Sandra Harrison.
Present.
Councillor Rob Kendrick.
Present.
Councillor Colin Matthews.
Present.
Councillor Robin Renshaw.
Present.
Councillor Angela White.
Present.
Councillor Mark Whittington.
Present.
Thank you. Councillor Stephen Woodliff. Councillor Stephen Woodliff. Okay, we'll come back there. Councillor Ray Woodson.
Present. Councillor Stephen Woodliff is present.
Thank you. And that was Councillor Ray Woodson. You said present at the same time. Was that right, Councillor Woodson?
Yes, correct.
Thank you. And Dr. Brian Wookey. Your microphone's off, Dr. Wookey.
Present. Can you hear me now?
Yes, thank you. Thank you very much. Thank you, Chairman.
Thank you, Trina. Okay, before continuing, I would like to once again welcome everyone who is in this appointment and listening online to this meeting of the House Scrutiny Committee. We have already confirmed which committee members are present. We also have present Councillor Mike Thompson, Executive Support Councillor for NHS Liaison and Community Engagement, and Dr. Cowley Chowdhury, Public Health Consultant for Lincolnshire County Council. Other participants will be introduced when we reach their item. I'd also like to ask members of the committee and other participants to type speak in the chat function when you wish to ask a question or make a contribution. Also, please turn off your camera and your microphone when not participating. Please keep your questions and contributions succinct and concise, and ideally no more than two questions per item. I'd also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'd now like to move to agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillor Mrs. Susanna Barker-Milan, and we have Councillor Mrs. Lucille Higgs as her replacement member. We've also received apologies from Councillor Glynis Scalesi and Councillor Rosemary Cabery-Brown. We have also had an apology for absence from Councillor Ms. Sue Woolley, Executive Councillor for NHS Liaison and Community Engagement. Thank you, Chairman.
Trina, in which case I'd like to move on to agenda item 2, declarations of members' interest. Do members have any interest to declare, please? No, okay, in which case I'd like to move on to agenda item 3, the minutes from the 11th of November 2020. I'd like to confirm the minutes of the meeting from page 3 to 13 as a correct record, and I plan on taking these on block. So can I ask for a proposer and a seconder, please? Councillor Brewis.
I'm happy to propose that we accept those as a true record of the meeting. I so move.
Thank you. And do I have a seconder? Is that you, Councillor Woodson?
Yes, Chairman, yeah.
Thank you. So that's been proposed and seconded. Trina, do we need a roll call on the minutes?
We do, Chairman.
Okay, in which case I'll hand over to you for the roll call, please, Trina.
Thank you, Chairman. So if you can please, when I call your name, whether you are for, against or abstain. Councillor Carl Macy.
For.
Councillor Chris Brewis.
4.
Councillor Bill Bilton,
4.
Councillor Matthew Fido,
4.
Mrs. Lucille Higgs,
4.
so Mrs. Sandra Harrison. Your microphone's off, Mrs. Harrison.
Sorry, 4.
Thank you. Councillor Rob Kendrick.
4.
Thank you. Councillor Colin Matthews.
4.
Councillor Robin Renshaw.
4.
Angela White.
4.
Councillor Mark Whittington.
4.
Councillor Stephen Woodliff.
4.
Thank you. And Councillor Ray Woodson.
4.
That's carried then, Chairman.
Thank you. Just to confirm, those minutes are carried, in which case I'd like to move straight on to agenda item 4, the chairman's announcements. Our chairman's announcements have been circulated with the agenda. There have been 2 supplements. The first one containing a briefing paper from East Midlands Ambulance Service, which was circulated on the 11th of December. And the second supplement was issued last night. One of the additional items relates directly to an ongoing legal case, and I do not feel it will be appropriate to open this item for discussion, though the committee can freely discuss the other items as part of the work programme item. I propose to note the chairman's announcements and supplementary announcements. Is there any dissent?
Could I, if that is a seconding of that, and can I also thank you and Simon and all those who keep us regularly informed. I find being kept informed about what's going on immensely useful, and I'm extremely grateful. Thank you, Chairman.
Thank you, Councillor Brewis. If there is no dissent, we plan on taking those as being noted, in which case we should be moving on to agenda item 5 now. However, Mark Brassington, the Director of Improvement and Integration for ULHT, unfortunately is unwell this morning and won't be able to attend. Therefore, I have been asked to delay this till 10:30, as the Chief Executive, Andrew Morgan, will be presenting alongside Simon Evans, the Chief Operating Officer for United Kingdom Hospital Trust. In which case, I propose that we move directly to agenda item 7, which is the work programme. Simon.
Yes, good morning. Thank you, Chairman. There are 3 parts to the work programme item this morning. The first part is the standard consideration of the items listed for forthcoming meetings, which begin on page 42 and continue on to page 43 of the agenda pack. The second element is to consider if the committee has any questions which can be put to the East Midlands Ambulance Service following the briefing paper which was issued last week. Just as a reminder, the East Midlands Ambulance Service had been asked to attend the previous meeting on the 11th of November, and then they requested a deferral through work pressures. A similar thing has happened on this occasion, but we have received a briefing paper which has been circulated, and they have said that they will respond in writing to any questions which the committee compiles today and can be sent on to them. And the third element is in relation to the date of the March meeting. It's understood that the district councils will be issuing notices of election on the 22nd of March for the county council elections. Notices of election technically begin the pre-election period. So as the committee listed on the 24th of, currently listed on the 24th of March, is 3 days inside that pre-election period, that there is a proposal to reschedule that meeting into the previous week on the afternoon of Tuesday, the 16th of March. So those are the 3 elements which I know that 3 parts to this item today, which I would ask the committee to consider. Thank you.
Thank you, Simon. I think it's probably also appropriate to mention that in our pre-meeting, we have spoken to our NHS colleagues who are saying they are under immense pressure at the moment in time due to COVID. And they have made a request that the committee only consider one substantive item in relation to whether it be Lincolnshire Community Health Services, Lincolnshire's Partnership Foundation Trust, or United Lincolnshire Hospitals Trusts moving forward, at least while we're in the midst of this pandemic and the amount of pressure that is on the local trusts. So that is something, and you may have noticed today that the agenda is slightly lighter than normal. I'll also bear that in mind. Councillor Renshaw, you'd like to come on, please.
Thank you, Chairman. I'm getting a lot of residents with a lot of problems about accessing primary care services and the wide disparity between different types of services. There seems to be no uniformity across the piece. And bearing that in mind, and I won't want an immediate paper because it's only 2 or 3 months since we had an update from the Primary Care Trust. I think it would be opportune before we all break for the elections in March to have an item on that. I'd be quite happy if it was even March, but I think it's important, bearing in mind the feedback we're getting from residents. They've got genuine concerns. It's distressing in some cases for them, and you know, I can't turn a blind eye to that anyhow. Thank you.
Thank you, Councillor Renshaw. Yeah, I think, as you recall, it was something that we raised last month as well, and we have had some feedback from the clinical commissioning group. I think probably most members here will have had very similar issues to you. It's incredibly frustrating at the moment in time, and I understand where you're coming from exactly. So yes, more than happy to look at trying to bring that back at some point, as you say, before the election period. And I'm sure that this will be noted down. And I think, if I also may suggest, if you have any specific issues or people that have came to you, if you could feed them in either via Simon so that we can get them into Sarah Jane Mills. She is interested in hearing where there are individual cases that are coming along to you. I myself have been feeding them also. Thank you for that, Councillor Renshaw. Councillor Brewis.
Thank you, Chairman. Yeah, mine's brief. I think we have to understand that we're in a very difficult position and respect the unique problems that the branches of the health service are suffering. And I echo what Robin mentioned as well. But I think if we can put our queries in between meetings, we're more likely to get a meaningful answer. And I think we've got to respect the fact that we're in a uniquely difficult time. We all know that. And I have an uneasy feeling that if the breaks are taken off over Christmas, then January will be a month we will want to forget for the rest of our lives.
Thank you, Councillor Brewis. Absolutely, I fully agree with you. And this is one of the reasons why we continue to push to ensure that health scrutiny continues over this period of time, because there are a lot of issues that residents are facing. And I think if people like Health Watch and ourselves aren't there to help them, then it does become incredibly difficult and it doesn't feel like anyone's scrutinising correctly, even though we do accept they're under immense pressure. Councillor Woodson.
Yes, thank you, Chairman. Do you remember last meeting we debated the Lakeside doctor's surgery closure in Stanford? Did we get any feedback following that meeting?
We did, yes, and it's within the chairman's announcements.
Right.
But as I say, I think, Simon, would you like to come in further? Because I think discussions are still taking place as the official line, if I understand correctly.
Right.
Simon?
Yes, thank you, Chairman. Yes, that is the case. Discussions are continuing between the CCG and Lakeside about the future of St Mary's Medical Centre, Stamford. But there is no further information that I have at this stage.
I can assure you, though, it remains on the agenda, and it is something that we are, as you can see, keeping a very close watching eye on. And as soon as we know anything, we will feed through, because it's a concern, of course, with those residents, much the same as the situation we had in Grantham as well. So
that's good. Thank you very much, Steve, Chairman. Thank you.
Councillor Whittington.
Thanks, Mr. Chairman. My apologies if you hear some drilling. We've got some maintenance people in today, so I may have to shoot off at some point. Yeah, I mean, an update on the Wolfthorpe by Beaver. practice which we discussed at the last meeting. And Sarah Jane Mills said that at some point the decision on the future would be discussed at a meeting of the CCG Primary Care Board. My understanding is that that is now going to take place at their January meeting, which I believe is on the 11th of January, which I think is the same day as our next health scrutiny meeting. So there's an update on that. And in terms of the sort of general view about, I appreciate it's a very, very difficult time for the NHS. I can see why they'd want to keep, items to a minimum. If there is some way of, during this time to have some kind of sort of informal flow of information, I think that would be quite useful in terms of, if we've got any concerns or questions to raise. I'm just wondering potentially if it would be possible, to see, even if it's just one or two sides of A4 from the local NHS, just a bit of an update on what's happening, might be useful. Doesn't have to be a full report, but just a couple of sides of A4, Carl, might be just quite useful, just to keep us up to date with what's happening. Thanks, Mr. Chair. Thank you.
Thank you. Yeah, I mean, we have had the offer of having perhaps an informal meeting at some point, and we'll probably look at trying to do something similar. What I was very keen was that we did keep these meetings open for the public side of things, so that it can be seen that we are addressing the issues that are coming forwards. I do know when we've asked for more detailed information, even in regards to ULH, they have said to us that they are under too much pressure to be spending too much time creating a report. But as you say, perhaps an A4 or two sides of A4, maybe something we can certainly push forward. I will raise again with the NHS. Okay, I have no further speakers, although I've just noticed Councillor Woodliff has asked, are we due for a report on the performance of the county's NHS dental services? I think it is in the work programme, but it wasn't that long ago that we did have an update. And of course, there is a little bit of an update in terms of my chairman's announcements. Simon, when are we roughly due now again to have the NHS dental side of things back?
Thank you, Chairman. We could look to list an update from NHS England Improvement on dental services. They have been issuing briefings fairly regularly since June, when dental services restarted, so to speak, and they've been updating gradually, but we've not had anyone from NHS England or Improvement before the committee, but I could certainly perhaps try and see if they would be free for one of the meetings between January and March. If that's,
I think that would be a good foot forward.
Yeah.
Okay, any further comments? No, in which case I'd like to propose that the work programme be noted, that a list of questions be submitted to the East Midlands Ambulance Service NHS Trust. What I would suggest is that perhaps if members have time to think over some questions and perhaps email them directly into Simon, we can try and compile something to go through and get some answers upon. I found it a very useful report, and I thought it was very in-depth, so it may be that there's not that many at the moment in time. However, I am of the view that perhaps we should be trying again at some point again within January till March, that we try and get EMAS in front of us, perhaps with a little bit more of the figures of how they're dealing with the ambulance response programme and so on. So I do think we'll push forward with that as well. I'd also like to propose that the committee's meeting on the 24th of March be rescheduled to 2 p.m. on Tuesday the 16th of March to avoid the third situation. Is there any dissent?
Happy to second that, Chairman.
Thank you, Councillor Brewis. In which case, if there is no dissent, I will take that as agreed. Thank you. In which case, we will move back to agenda item 5, but as I said, we are waiting for Andrew Morgan and Simon Evans to check in. So I think it's probably best for the moment in time that we do just take a small recess until 10:30.
Good morning, Chairman.
Good morning, Trina, and thank you and welcome back to Health Scrutiny. Can I ask you to perform the roll call, please, for members?
Yes, certainly, Chairman. Councillor Carl Macy,
Present.
Councillor Chris Brewis,
Present.
Councillor Bill Bilton,
Present.
Councillor Matthew Fido,
Present.
Councillor Mrs. Lucille Higgs,
Present.
Councillor Mrs. Sandra Harrison,
Present.
Councillor Rob Kendrick,
Present.
Councillor Colin Matthews,
Present.
Councillor Robin Renshaw,
Present.
Councillor Angela White.
Present.
Thank you. Councillor Mark Whittington. Councillor Stephen Woodliff.
Present.
Thank you.
Councillor
Councillor Ray
Woodliff.
Woodson.
Present.
Dr. Brian Wookey.
Present.
And I'll just go back to Councillor Mark Whittington.
Thank you.
He's not there at the moment, Chairman, but he will probably join the meeting. We'll check later. Okay. Thank
That's
you.
great, thank you very much. In which case, we're starting back at agenda item 5, United Lincolnshire Hospitals NHS Trust COVID-19 update. You'll find this on pages 25 to 34 of the agenda pack. And I would like to welcome our presenters from United Lincolnshire Hospital Trust, Andrew Morgan, Chief Executive, and Simon Evans, Chief Operating Officer. I will hand you over to run us through the paper and we'll take questions at the end if that's okay. Thank you.
Okay, Chair, thank you very much. Apologies, we mucked about the timing of your meeting today. It should have been Mark Brassington, one of our directors and the Deputy Chief Exec here instead of me, but unfortunately he's not well today, so I've stepped in for him. So we've done a bit of upward delegation. So I'll just do a quick overview, if I may. And as you said, we have Simon Evans with us, who is our Chief Operating Officer, who I think will have some of the detail if people need to go through detail.
Thank you.
So I suppose putting into context, there's a number of things all on the go at the moment, all of them linked, but all of them really high priority. So what we're managing at the moment is clearly COVID wave 2, alongside the beginning of winter pressures. It comes around at the usual time of year, alongside the recovery of some of the planned activity that was paused during wave 1 of COVID. We've also got the new COVID vaccine to manage. We've got Brexit, whatever that may bring when the period ends at the end of December. And then we've got all of the usual business as usual around running an organisation such as ours. So you'll hear us sort of mix and match some of those, but they are all linked together and they all do have an impact on the offer that we're giving to the public and our ability to staff that offer. So if I focus on the COVID element of that, we are in wave 2 at the moment. The NHS is at level 4 as part of the national emergency planning. So that's the highest level that the NHS sets as part of its emergency planning and response. And that's very much a level that is about national command and control. So in effect, we often receive instructions of things that we will do, or some decisions get reserved to NHS England on behalf of the Secretary of State. So we're back into that level, having ducked down to level 3 in the summer period. So in terms of COVID inpatients in the trust at the moment, as of yesterday, we had 204 COVID inpatients. That was 126 at Lincoln and 78 at Pilgrim. In wave 2, we peaked at just over 250. I think we got to 253 at the start of December. And just to put wave 2 into context with wave 1, the highest figure of COVID inpatients that we reached in wave 1 was around about the middle of April, when we had a 104 COVID inpatients. So you'll see that wave 2 has had a much more significant impact on the trust. And if I look back over the last 7 days, in that 7-day period, so I'm going back to the 8th of December now, we have seen through the organisation an additional 153 COVID inpatients. We've been able to discharge 121 COVID inpatients. Sadly, in that week, 57 patients died in the hospital. But in terms of the current numbers, as I've said, we're at 204 yesterday. If I look back a week, we were at 244. So the current numbers gone down, partly as a result of discharges, partly as a result of, sadly, patients dying, but also a number of patients stepping down from being a COVID inpatient, but they are still in the hospital. You will have seen over recent weeks, we have declared some internal critical incidents. That's when we reach a position when our sort of normal functioning is impacted to the extent that it calls into question our ability to maintain some of those services. They last for a relatively short period. They are dealt with by internal actions as well as support from our partners, but they tend to be driven by staffing levels reaching a bit of a crisis, with shifts not being filled on the front line, crowded A&E departments and people waiting too long in the department, particularly when they're waiting for a bed elsewhere in the trust. I have to say, during those relatively short critical incidents, but also I think throughout the COVID wave 1 and wave 2, we have had significant support and partnership working right the way across health and social care. I would include the County Council in that, and I would include our health trust partners and the voluntary sector. I think it's been a great team effort to try and manage the situation. We do still have a number of significant pressures, many of them related to our staffing levels. We have significant absences at the moment, partly driven by COVID. So either staff who've got COVID or having to self-isolate because they have either been in contact with somebody or they live with somebody who's got COVID. Recent reported figures, we had about 1,140 staff absent. That is a significant proportion. That's around about 13–14% of our workforce not being around. That does make it very difficult to manage some of the services that Simon's responsible for. When you overlay on that the vacancies, which I know your committee is already aware of, that's a double whammy, if you like, around our ability to provide services. So that's some of the pressures that drives what we face. We don't just accept that position. We do everything possible to try and keep our staff healthy and well. We've got a very comprehensive system level health and well-being offer to our workforce. We've currently vaccinated 81% of our frontline staff with the flu vaccine. We've got lateral flow tests for our frontline staff, and we've just recently started through the COVID vaccine programme to vaccinate the highest priority or highest risk NHS staff, not just in this trust, but across the system. Moving on to the vaccine, because that's clearly a key part of where we are. We at ULHT are one of the 50 national hub hospitals. That is focused on the Lincoln County site, so it's specific to Lincoln County. That is the one that has been signed off as being appropriate to manage the COVID vaccine. We started last Tuesday. We operate on two different parts of our site. Clinic 7, which is in the outpatients department, we use for those over 80s that would have been on our site anyway for an outpatient appointment or have been an inpatient but are about to be discharged. So we offer vaccines to those over 80s at Clinic 7, and we're using the Lincoln County Hospital Social Club for the other priority groups, which are care home workers and those members of the health family who are staff who are at highest risk. So we've been running 7 or 8 days now. It's going well. I'm not allowed to give you the figures. The politicians wish to retain that ability to report on figures. So if you're about to ask me how many have we done, I cannot tell you how many we have done, but we are going along according to plan. And obviously our primary care network colleagues have now started their contribution towards the vaccine programme with their centres opening up, one in Grantham, one in Louth, and further due to open as soon as all the necessary arrangements are in place. So that's my overview, Chair. I'll hand over to Simon in case he either wants to correct anything I've just said there, or whether there's any specifics that he wants to fill in any of the gaps. So Simon, is there anything you need to add to that?
No, thanks, and well remembered. Everything was spot on there, well trained. Thank you. Just one other thing that I think is probably worth mentioning is obviously how we're managing our elective and our cancer patients during what is a really difficult time. And I think we've reported back to the committee previously and had a significant discussion around how we've been managing with the Grantham site. I'm pleased to say we've now done over 5,000 treatments over at Grantham since we've put the model in place, and we have been able to sustain much of that even during this very difficult wave 2 period with all the challenges that we've had. And that's been really important just because of obviously the critical nature of some of the cancer treatments that we have to deliver. Unfortunately, at Pilgrim and Lincoln, we haven't always been able to maintain our services as the level of COVID has increased in our hospitals, and it's got to a point on occasions where we have had to pause cancer operating at those 2 sites just because of the number of staff and number of patients who have been COVID positive or query positive. We do restart that when we're able to for a very small number of patients who have time critical nature for their treatments, but the Grantham site continues to safely operate and treat those really vulnerable patients for us despite what's happening. Other than that, I think Andrew's articulated everything that was in the paper and also the most recent updates in terms of figures. So happy to take any questions. Thank you.
That's great. Thank you very much for that and for the run through. Andrew, just to pick up on a point, obviously you've just said that you can't say how many people have received the vaccination. Is that the same for how many staff have received the vaccination? And failing that, if you can't give us those figures, can you perhaps tell us what the timescale is for full rollout within ULHT?
Okay, I feel really bad not being able to give you the figures, because that certainly is not my normal style. I go on lots of media outlets and I go to lots of meetings where I give as many figures about the trust as possible, but it's very clear in a level 4 national pandemic, the national politicians do not give consent for us to release the figures. Just to remind people, it's the over 80s, care home and NHS staff, not just ULHT and NHS staff, but across Lincolnshire, including the ambulance trust and including other bits of the NHS, such as those blood and transfusion colleagues who might work in Lincolnshire. It's difficult to be precise about timing, because what we don't know is how secure the vaccine supply is, because we've got the one vaccine at the moment, the Pfizer-BioNTech one, which, as you know, has significant storage, transportation and movement issues. It's quite a complex vaccine, which is why there's a limited number of hubs that have been approved to do it. And the priority order for the vaccine is clear. It should be the over 80s, then it's care home workers, then it's NHS staff, subject to you must not waste any vaccines at the sort of end of the day. So occasionally there's a bit of a sweep up around that. What we're trying to get to with all of that planning is that we want to be able to have vaccinated all of the NHS staff in the system by the end of March. But there's a lot of planning that needs to happen to be able to make that a reality. So at the moment, that's an aspiration. I don't have the supply chain of vaccines to be able to prove that at the moment, but that's the planning basis, Chair, on which we are proceeding. We're starting certainly at ULHT with the most high risk NHS staff who work with us. So that's people about their individual circumstances that puts them at risk, including our BAME colleagues. It's also about those people who are exposed on a daily basis to potential COVID patients. And then the third category is about exposure more generally to vulnerable people. We're hoping to do those high risk people. We think there's about 1,200 at ULHT, hoping to do all of those by the middle of January. And as I say, we'd like to get all NHS staff done by the end of March. But please don't hold me to that at the moment, because I haven't got the detail.
No, thank you. Very useful. Thank you for that. OK, I'll now hand over to questions. I've got Councillor Whittington first, please.
Thank you, Mr. Chairman. Thank you, Andrew and Simon, for your update. I mean, in the past, at times I've been a little critical of the health service, as you probably know, but I believe this is the time to actually give praise to the health service, because I appreciate the very difficult times you're going through at the moment. And I believe, just pass on my very, very best wishes to everybody involved in rolling this out. And we really appreciate the difficulties that you've got, and we really, I guess at times like this, really do truly value the NHS and what it actually stands for. In your presentation, Andrew, I just want to give a little bit of first-hand feedback. In Grantham, obviously, we've got this sort of extension at Moy Park on Gunnerby Road. And I actually used that. I was an outpatient there in the orthotics department about a month ago. I sort of went in there, and to be perfectly honest, you wouldn't know you weren't in an NHS building. It just, you just walk in there and it just looks like an NHS facility. It's great. I can appreciate the difficulties the staff are having, because in the waiting room there's only 6 chairs, and it's a lot, and obviously people are only coming in, at a specific time for their appointment. And certainly the treatment room I was treated in was very, very well in terms of equipment and facilities was great. And the bloke I saw said, you know, it's the facilities here are really good, and the staff were managing the flow through of dealing with the situation in a very, very professional way. So many congratulations to that, and thank you on behalf of the people of Grantham for making that facility available. I think it's certainly appreciated. Some of the questions I was going to ask, you've previously covered in your presentation, but you were talking about sort of the number of patients you've got, and it's sort of around about 200 at the moment. In overall terms of your beds, Andrew or Simon, what percentage of your total beds roughly are currently being taken up by COVID patients? Would be my first question. And my second one really is to sort of, because I'm not particularly in favour of the government easing the restrictions over Christmas, because potentially I think we could have a very, very difficult and very, very dangerous January as a result of this. And my big fear is that if we do have a reduction in the restriction levels, we get a big sort of almost like a third wave in January and a bad winter. My fear would be for you guys would be a almost perfect storm of a bad winter on top of a further spike in COVID. And just, I mean, I know it's an unthinkable question, but how would you cope if you did get that kind of perfect storm of everything coming at once, especially in terms of, you know, with regards to the fact that I appreciate you've got a large number of staff vacancies and a lot of staff off, and it's just, I think you're in a terribly invidious position here, and I just, my heart really does go out to you, but just a little bit of what you could do if you did get a really difficult perfect storm situation. Thank you very much.
Okay, thank you, and thank you for your compliments at the start of that, Councillor. I will certainly pass them on to our colleagues, including at Moy Park. I have been in there myself more than once, and you're right, it is a very good temporary facility that we set up there. Simon, do you just want to do the bed percentage figure, and then I'll come back to the second, or you can also chip in about what you'd have to do operationally if it got too bad.
Yes, certainly, thank you. So the peak that we've got to is just short of 30% of all of our inpatient beds had COVID positive patients in, and nearly the same again had patients who we had yet to designate or have a confirmed status on, what we call our query COVID patients. So about 60% overall of all of our inpatient capacity had COVID or query COVID. Now, we do lots of things in order to isolate and reconfigure our hospitals, and we've certainly adapted our approach to how we designate wards, and we use our facilities very differently now as we would have done perhaps this time last year in terms of isolation capacity, and that's how we manage that on a day-to-day basis. As you say, staffing challenges are absolutely a limiting factor in that often we aren't able to always open up extra capacity in order to make some of those shifts and then rebalance. And that really is sort of that point of your second queries, is how would we manage if we had that perfect storm? I mean, I think we've certainly seen all elements of the perfect storm in some sort of measure over the last few weeks. We've seen our staffing, a significant increase in normal emergency winter demand, so chest pains, the usual winter difficulties, also at the same time as our highest rate of COVID ever recorded as well. And we've learned a lot in how we manage that operationally. We are working really closely with the wider system, and also slightly out our NHSE colleagues and the region as well, to try and balance the demands on our hospitals at different times with the wider region to make sure that we use all the levers available to us. But I'm pleased to say we've developed some really innovative responses, working with colleagues in LCHS, LPFT, the voluntary sector, and of course our social care colleagues as well, about how we best use the resources that we have available to us. And we'll build more of that in terms of our planning in the new year. And we are we are putting together contingency plans, assuming that sadly, you know, that worst case that you've described there does happen, and we are now preparing for that. I don't know whether Andrew wants to add any more to that.
Yeah, I mean, thank you. I mean, as Simon says, you sort of plan for the worst and hope for the best. I've done quite a few sort of media interviews about where we are as a trust, and I know some of my media colleagues like to try and draw me on an opinion about either tier levels or Christmas arrangements, and that's a matter for politicians to decide about that, and I certainly don't envy the politicians having to do that. All I ever do say is to encourage people to follow the hands, face, space message, whatever tier we're in, whatever the Christmas arrangements are. Do follow the rules that are in force, make informed decisions, minimise risk, and just be aware of what you're doing and what the consequences should be. And that's irrespective of whatever the Christmas rules are or whatever tier Lincolnshire is in. I think the public gave us huge support during wave one. Would absolutely agree with Councillor Whittington's comments. Yeah, I'm unashamedly a lifer, as it were, in the NHS, been in it 38 years now. It's undoubtedly the best bit of our society. Love it dearly, want it to be good, want it to be better. And I would just continue to encourage the public and their representatives to do everything possible to allow us to look after the patients that we've got and to keep everyone safe, including my workforce as well. Thank you, Chair.
Thank you, and thank you, Councillor Whittington. I've now got Councillor Brewis.
Thank you, Chairman. I also share the sympathy we all have for our health colleagues, and also our absolute admiration of what they're doing in this uniquely difficult position. And I share what's already been said about that, and I hope you'll convey all our wishes to them, that we rely on them and hope. But you did particularly say that the NHS staff would be vaccinated by the end of March 2021. And whilst I'm not entirely cynical, I think, does that mean that the full rollout to the entire population will be in March 22? I just wonder whether we know anything on that one. My other one is the fact that you cannot release the figures by government diktat. I may be the only one. I find that absolutely mind-boggling from a government whose messages on the whole crisis from the start have been so confusing that a lot of people don't know where they are, and they are so confusing, and also they're made at such short notice. And how for example, the hospitality industry manages to keep going when they're told with less than 24 hours notice that their particular tier is going to change. It's costing them an awful lot, and it seems to be very difficult. My other point is I completely share Mark Whittington's concern about the idea of taking the brakes off at Christmas. I think that is completely and utterly bonkers, and in January, people are going to regret it very, very much. And it just seems to me that has got to be the most crackpot idea that's ever been come up with. Because they're making vaccination voluntary and not compulsory, and I happen to believe that this is one example where it should be compulsory. I don't think there should be any excuse for people not doing it. That's a personal view. What my second question after the one about the rollout to the general population is, what do we do about people who are, and I live a long way away, as you know, I'm right out in the Eastern Hemisphere. For example, I have residents who are 7 miles from Queen Elizabeth Hospital in Lynn and 59 miles from Lincoln. So will people be able, and it's absolutely essential, will people be able to get vaccinations out of county? Because the idea of travelling to Lincoln is completely impractical for most people, because it would take them 2 days to do it on public transport at the moment. Thank you.
Okay, thank you. I mean, it's difficult to be precise about timings of rollout of vaccine, because we've had one vaccine approved at the moment. We're waiting for hopefully positive confirmation about other vaccines. That once that's done and more doses are available and more primary care network centres are open to vaccinate, we'll then get a clearer view as to how quickly we can do the whole population. The Joint Committee on Vaccination and Immunisation has set the priority list for the sort of order in which patients should be done, with a very strong focus on age being one of the key determinants of this disease. So starting with the oldest first. So I can't sort of hazard a date as to when it will be fully rolled out. And I know the Secretary of State gets asked quite frequently in the Commons, can he give a date? And he can't, and I can't. I gave you a working assumption of when we're hoping to do our staff by, but again, I can't be held to that because it's about vaccine availability. On your second point about vaccinations being local, this is a programme that's building up. I clearly am accountable for what goes on in ULHT, but we've seen in Grantham and Louth over the last day or so that they've now started their local vaccination centres. I would expect more of those to be opening over the coming weeks. And I think, Councillor, that should then answer your second question about being able to get your vaccinations more local and not having to take a 2-day trip to Lincoln County. That's where I anticipate the overwhelming majority of your constituents will get their vaccine in a local centre run by the primary care network. There will also be large vaccination centres set up as more vaccine comes on, but again, don't have a date when those will be up and running. It is still really early days in the vaccination programme, but still fantastic news that we are where we are and we have actually started the vaccination. So sorry if that's a bit of a vague answer.
No,
I can't be more precise at such an early stage.
If I can ever briefly say, I agree with you totally that it's an incredibly quick thing to get a vaccine of any sort. It's extraordinary how quickly that has come forward, however difficult it is to transport and look after. But where we live out in the Far East, local basically means Wisbech or Kings Lynn. That's what we're talking about. Unless it's Holbeach or Long Sutton, it means Wisbech or Kings Lynn. Even Spalding is a long way away by public transport. Johnson Hospital is a 3.5-mile round trip by public transport. There is nowhere local within Lincolnshire, unless you mean Holbeach or Long Sutton.
Yes, and I think, had you got John Turner here, the accountable officer of the CCG, rather than me, he might have been able to tell you more about what the GPs and the primary care networks are up to. I'm afraid you've got me today, and I can only really talk about what the hospital's up to. Thanks.
Thank you, Chris.
Indeed, I appreciate that.
Thank you, Chris, and thank you, Andrew. Okay, I will now move over to Councillor Ray Woodson. Before I do, I still have 7 speakers, and I do plan on closing the debate at that point because we do have Derek Ward. Obviously, we're slightly delayed today, so I'll hand over to you, Ray. Thank you for your question.
Thank you very much indeed, Mr. Chairman. Andrew, good morning, and Simon, good morning. First of all, may I add my thanks to you and your staff for the great work they're doing at all the hospitals in Lincolnshire, and it is much appreciated. Returning to Grantham Green site, the legislation is there to keep it going temporarily to the 31st of March. How much notice will you need, or do you need, to give the government to extend that period? Because I can't see that period being finalised date on that date. I can see it being extended. Is there legislation in place already to move that date?
I don't think it's about legislation, and we certainly made no decision to extend it beyond the end of March, just in case anyone wishes to quote your question as my response. We made the decision back in June that we thought it would run till the end of March, and you base those decisions on what you know at that particular moment. We have agreed to have quarterly reviews. We had one that reported to our board in October. The next one will report to the February board. At that point, I would anticipate the board will come to a view as to, is it about to end at the end of March? Or if we're going to extend it, what action do we need to put in place to extend it? I don't think that can just be we make a decision in isolation. I would expect further engagement with colleagues in the community, with our partners in the system, that if we were looking to extend, that would have to have some public involvement and engagement. But the board hasn't met to make that decision as yet. I'm giving you my view as the chief exec, that in February that's the sort of discussion I would expect.
Okay, and the second question, Mr. Chairman, is you say 1,140 staff are absent. Have you managed to retain or obtain bank or agency staff to fill those vacancies? Are you still having a real big shortfall of staff?
We do fill a number of shifts with bank and agency. I think on occasion that's proving more difficult than it used to be, particularly as some bank and agency staff themselves are absent from work or unavailable. There will also be some people that don't wish to go to particular COVID wards or sites, so that's another constraining factor. But Simon, I don't know if you wish to add anything to that.
Thank you. Yeah, I mean, we have been successful since we've started to see the real challenges. We've managed to add nearly 100 people to our nursing bank, which has been really helpful. And NHSE and system colleagues have really helped us with sort of publicising that we need some help. And if you are a registered or practitioner of any sort, then please come and work with us. We'd love to have you in our hospitals, but it's not quite offsetting that level. 100 against the 1,000. It's clearly not matching that. And as Andrew said, we have seen a significant reduction in the amount of agency who normally would work with us, in part because they're off sick, but also in part that there are many other organisations around us in other regions who are also increasing the amount of agency, who perhaps in the past wouldn't have normally used that. And again, that's another thing that our NHSE colleagues are helping us with. We're trying to balance that out so that we don't have an exodus of people who used to work in Lincolnshire, perhaps moving to Nottinghamshire or Derbyshire or other places like that.
Okay, thank you. Thank you very much. Thank you, Chairman.
Thank you, Councillor Woodson. Just building on to Councillor Woodson's first question, on page 30, the first paragraph, the report states that triggers have not been met at Grantham Hospital to return it to pre-COVID-19 levels for the last month. However, what is the current picture, and what triggers would cause this reversion, and in turn, how quickly?
So I can probably answer that. So in terms of the numbers that we've described there, there were 6 indicators that were put in our quarterly review, which we continue to look at. They range across a number of scenarios, one of which is a major incident and a mutual aid call from a partner organisation, such as North West Anglia, right through to a need to be able to surge for critical care and essentially increase very significantly the amount of staff that are having to work in our critical care, and therefore have to close down certain elements of services across the board. So we look at all of those indicators pretty much on a daily basis when we go into escalation, and none of those have been met. I'm pleased to say. In terms of if we were to face one of those indicators suggesting that actually that has been triggered and we would then need to revert back to a previous model, the original timescale was that it would take us nearly 6 weeks in order to fully re-implement safely the original model. And I think the key bit is the safe transition, obviously in the same way that it took us about that same length of time in order to put some of that in place. It took us about 12 weeks in total to get all of it in place in the original model when we first switched the green site on. That's the likely timescale that we would need to revert back.
Okay, thank you for that answer. That's helpful. I've now got Councillor Thompson, please.
Thank you, Chairman. Sorry. Recent press reports have indicated nearly 30% of COVID-19 patients in ULHT are reported to have contracted the disease in hospital, placing the trust 7th in the country for hospital-acquired infections. Between August and November, 762 cases were reported, with 225 caught in hospital. What is the outcome of these cases compared with non-hospital acquired infection, and what steps are being taken or have been taken to address this? Thank you.
Do you want to do the numbers in a minute, Simon? And I'll just start with the general comment. I think we see across the country that those hospital-acquired or nosocomial rates tend to correlate with high levels of community infection. So as infection goes up in the community, bear in mind that's where people live and that's where our staff live and work. As that rate goes up, the Office for National Statistics recent reports that I've seen shows that there is that correlation between community rates going up and nosocomial rates in hospital. So as I look across the Midlands and look at our rates compared to other trusts who've got a number of or a high number of COVID inpatients and a high level in the community, they're the same trusts that have levels of nosocomial not dissimilar to ours. Our rates are reducing. I think the figures that you were quoting were from one of the national newspapers that took the over 8-day figures. We also take the over 15-day figure. The over 8 tends to be what people say is a probable hospital acquired, whereas the over 15 is the definite hospital acquired definition. And I now just wait to see if Simon's got any of those figures in front of him. Thank you.
Yes, absolutely. So that probable, as we sometimes determine as intermediate, or that 8-day to 15-day, is 26% at the moment. It has been reducing slowly but consistently throughout the period. But our over 15 days, which are those ones, is actually down at a level of only 6%. And as Andrew said, another sort of corroborating factor and data that we look at is obviously our own sickness and the amount of our own staff who are COVID positive or are isolating because they've been in contact with other colleagues who may be COVID positive as well. And clearly that is a very high number as well, and that has absolutely matched the community COVID numbers, which have been for some time amongst the highest, certainly in the Midlands region, but at times nationally starting to increase to very high levels as well. So with those are the sort of most up-to-date numbers of what we've got there, and we do spend a huge amount of time talking to NHSE colleagues and validating whether the actions that we're taking are appropriate and proportionate, given other centres who have seen high nosocomial numbers, and we are consistently applying all of the best practice that NHS England and our CQC colleagues have given us as sort of advice of how to manage this most effectively.
Okay, thank you. In which case I will bring in Dr. Wookey.
Thank you very much, Chairman. My question refers to page 28 of the ULHT report. At the bottom of page 28, the CEO Trust Overview, and it concerns the lateral flow tests which you're introducing for staff. And you mentioned that positive lateral flow would trigger a PCR swab, but we know that the lateral flow is not 100% reliable. In fact, some reports have suggested only that there might be a 20% false negative results from that test. And I'm wondering whether you feel it is safe to rely on that, and that a negative test might give a false sense of security. Obviously, in a hospital environment, it's a little bit different, but there are implications for doing something similar in care homes and visitors to care homes, where certainly I think we are very concerned that that sort of error rate would produce, certainly occasionally, a tragedy in a care home. And obviously hospitals are not quite the same, but I wonder if you've got some comments on that. Thanks.
So I can chip in if that's helpful, Andrew. And in terms of the lateral flow test, it's by no means the only thing that we're doing for our staff, and we absolutely recognise all those points that you raise about how useful it is. We have sort of health check process where staff are asked to essentially self-diagnose. Do they have symptoms? Are they showing any signs? Have they had any contact? Of course, we use the Trace app as well. So if out of hours, when they're not in the hospital, staff are encouraged to use the Track and Trace app, so that if they do come into contact with others that are then going to be positive, that they isolate appropriately as well. We have temperature checks in process. In fact, we're just about to give every single member of staff a thermometer, so that they not only look at this as they come onto site, but also they can do this at home, so that they have an accurate temperature check. And that suite of things is alongside, obviously, some of the more recent research that's been through the BMJ and other professional articles, which have identified that actually symptomatic staff are probably those that are the highest chance of transfer, and that they're sort of the asymptomatic are only a third as likely to sort of pass on COVID-19. And so they're the really critical ones, is to make sure that we don't have any staff who are symptomatic. So combining that with the lateral flow and then subsequently with the PCR, we believe that that's a good suite of measures in order to make sure that we don't have staff coming in and passing it on in hospitals. Of course, we'd encourage our colleagues in care homes as well. And I'm certainly, from what I hear, the similar sorts of approaches are also being applied in care homes around self-checking and symptomatics, and reaffirming that people should not be coming into work if they display any symptoms or if they're concerned. I don't know whether, Andrew, you wanted to add anything.
No, I would have given the same sweet answer, and probably would have also added, and in the meantime, while all of those things are going on, we keep reminding our colleagues about the importance of the hands, face, space message, both in work and out of work. So I think it's a combination of actions. We're not just relying on the lateral flow test, although staff did push to have lateral flow tests. The government have provided lateral flow tests, so we are using them at the moment. Thank you.
Can I very quickly come back, Chairman?
You may, yes, certainly.
Only to say that that's probably okay in a hospital setting, but I think we are very concerned that this may be transposed to care homes, and I think certainly there would be a lot of apprehension about relying on individual members of the public to rely on a lateral flow test and then go in and see an elderly relative at a care home. I think more work needs to be done. I know this is not your responsibility, but I think it is a worry that it could be taken as an example for use in care homes, and the present results I don't think would justify that on safety grounds.
Yeah, I understand the point. I think your next guest who's appearing after us, Derek Ward, might have a view on the evidence around. Well, there he is. He's already with us.
Thank you. Thanks, Andrew.
Thank you. Okay, in which case I've got Councillor Woodliff next, please.
Thank you, Chairman. Can you hear me?
Yes, we can hear you.
Okay, thank you. I'll put my camera on if it goes on. I'll leave the camera out. It's not doing it. I have two questions, really. The first one is regarding page 34 in the report. Is ULHT likely to achieve a break-even financial position in March, given the implication that the CCG is entirely responsible for the deficit? That's the way I read it on page 34. So, Mr. Morgan, are you able to answer that question?
Sorry, I was a bit slow there to press the button.
Oh, okay. If you want to read the question, I'll repeat what I said. Good morning, by the way. I think I don't know whether I've appeared or not. The question is regarding page 34.
Yeah, no, I've got the question.
Okay.
Yes, I mean the money is now managed as a system in Lincolnshire rather than just about individual organisations. So we will come in on our plan at year end, and as you say, in that year end position, Lincolnshire's currently looking like it will be 4 million out against the envelope that we were given. That deficit will sit with the CCG, not with us. But I'm not saying within that ULHT will have resolved all of its underlying financial issues, because we won't have done. This is about the envelope that's available. As a county, the 1.2, 1.3 billion figure, the first half of the year was dealt differently to the second half of the year because of the COVID pandemic. So what we're saying there is there's currently a 4 million gap. That will sit with the CCG, not with us. That's all that's saying.
Thank you. A second point really is you made the comment that the NHS is the best part of our society. Well, I'm sorry, I have to disagree. The education service is the best part of our society, because without an education service, we don't have an NHS or an economy or anything else. And I'm quite passionate about this, being a former teacher and also a governor, because I see the school being trashed at the present minute. And the NHS can ask for any money it likes and gets what it wants. And the schools have to go down their knees, some of them, and ask charities for money for essential services. I just think there's something fundamentally wrong here. It would be very good to see the NHS turn around and tell the government that the answer to the shortage of staff and so on lies within the education service, and they better get on and reinvest in education in a big way to bring up all the staff that we need. So we don't rely upon foreign national doctors and so on. We can generate them ourselves. It's all very well for government to talk about it, but they're not really doing it. And we need inside the schools real investment in much the same way that the NHS has enjoyed, because at the present minute, the schools are being trashed. That's really what I want to say. Yeah, I'd like to hear what you have to say, but that's my
I would say you're the politician, not me. Take that up with the national politicians. I'm accountable for my bit of the NHS. I do think it's the best bit of our society. I know you have a different view. I'll leave that one for you to pick up with national politicians.
The education service is a key to it.
No, thank you, Councillor Woodliff. I think
have your view and I have mine.
Concentrate on this.
Okay.
Right, thank you for that. We'll now move on to Councillor Kendrick, please. Councillor Kendrick.
Thank you, Chairman. So, sorry for the delay. Some of my questions actually have been asked in part to do with hospital-acquired infection. I still have a couple of questions. I'm not sure whether Simon will be able to, or Andrew will be able to answer them. I was just wondering, looking at the data for the number of inpatients with COVID, is there any differentiation in the data with showing those who have an underlying health condition and those who don't? I'm guessing perhaps that isn't that sort of sophisticated. And also, I was just wondering how this compares with, say, a bad flu season, and I can appreciate the concern that should we have that on top of COVID, we would have a very serious situation. So I was just wondering if there's any thoughts on that. I appreciate they're perhaps not something you'd have at your fingertips. Thank you, Chairman.
As luck would have it, we do look at those figures, and actually it's an extremely high proportion of COVID are recorded as having something else, another comorbidity, in excess of 90%. And this does differ slightly between different organisations, as there is an unfortunate category of other that is recorded as opposed to the specific other comorbidity or issue, and that's used differently between trusts, but it is fairly consistently very high across the board, and that's probably largely as you would expect, in that the most vulnerable in society when it comes to COVID are those that have other comorbidities, and that's why our elder population, who will almost by definition have more issues in the background, be the ones that are likely to be hospitalised.
Yeah, it's very interesting, very informative. Thank you. And on the point about how the incidents or the levels compare with the bad flu season, Simon, is it on par, or
the numbers that we have in hospital, in terms of hospitals, is significantly higher than we would ever experience in terms of a flu season. Again, flu season tends to be a mixture of people with flu and other things going off, which is why they're in hospital. But I don't believe we've ever recorded in our history up to 60% of the population, certainly 30% confirmed, with one single condition such as influenza or COVID.
Thank you, Derek. You'd like to come in, please?
Thank you. Yeah, it was just to say that in terms of average flu season in the UK, in terms of mortality, it bounces around quite a lot actually, but anywhere between 8 and 15,000 deaths nationally in a really bad flu season. As you'll know, Councillor Kendrick, the UK rate of deaths from COVID at the moment is 65,000, and we've not had a full year. We've not gone through winter yet. It can be 76 if you incorporate 76,000 deaths if you incorporate any deaths where COVID is mentioned on the death certificate, and more towards 80,000 if you look at excess seasonal mortality in the round. So clearly a lot more, a factor of 4 or 5 more than even a very bad flu year in terms of mortality.
Thank you very much. Thank you, Chairman. Thank you.
Thank you, and thank you for the clarification as well. Right, I now have the final speaker, which is Councillor Sandra Harrison.
Thank you, Chairman. Morning, Andrew. I represent the East Lindsey area, and historically many of our residents go to Grimsby Hospital. I'm wondering, are they taking our COVID patients at the moment? And if so, are those figures related, are they reflected in the figures that we have about affected cases? Thank you.
Thank you. The figures that I've quoted are figures for ULHT. So they're figures for Lincoln County and for Pilgrim. Any of our East Lindsey residents who've gone to Grimsby will be quoted in NLAG's figures.
Oh, right, thank you. So I apply direct to them, do I, if I want to know the numbers?
If you want to know the numbers of COVID patients in their trust, so it's a hospital-based
Yes,
as opposed to a population based, you would need to go to them to ask them how many COVID inpatients have they got at the moment. I don't know. Simon might know what the number is because he seems to know a whole set of figures, but I don't know their particular figures.
Thank you, Sandra. It's something that we can look at as well. I'm sure that Simon Evans can contact NLAG and perhaps ask the question. We can do it in chairman's announcements next month. So hopefully that helps. Right, thank you. I've just got one question, if I may. That's on page 28, bullet point 4. The report refers to the acute services review and how it is now likely to be considered by the national panel. Do you know when this is likely to happen, and how soon after do you feel this is likely to go out to the public consultation?
Okay, I'll just remind myself what I said in my own report. I think I said we just had the regional review. We have just had some questions back following that regional review that we need to respond to. So we're working on those at the moment. I don't have a date when the regional panel, sorry, the national panel would meet, because they, I presume, would say, well, we're dependent on ULHT and the system coming back with the answers to the regional questions. The consultation itself is a matter for the CCG, not for me. So again, I think you probably need to speak to John Turner about when his board would envisage the consultation actually taking place. He might say, well, it depends how quickly the national panel comes back. Could be a factor then of your local elections taking place next May, I presume, the delayed ones. That's a factor we'd have to take into account. I'm just clear as the ULHT chief executive that I want to get on with this. It's been hanging around far too long, if I can use that technical term. I really do think we need to get the answer to the questions that have been raised, get it into the national panel as quickly as possible, get their decision as quickly as possible, and then consult as soon as legal and decent, because we need to move on from this.
No, I'd agree fully. Thank you for that, Andrew. In which case, we've had all the speakers now. I'm going to move to a proposal, and that proposal is to record the committee's support and thanks to all staff at United Lincolnshire Hospitals NHS Trust for their efforts in maintaining NHS services in Lincolnshire. And secondly, to receive a further update in February prior to any possible reversions or changes being made. Do I have a seconder for that proposal, please? Thank you, Councillor Brewis.
Chairman.
Thank you. In which case, I don't plan on taking it on roll call. So is there any dissent to this proposal if it's raised now? No, in which case I believe that that is carried. Thank you all. And I'd just like to thank you, Andrew, and you, Simon. We do appreciate your time, and I know pressures you're under at the moment, and wish you a very Merry Christmas.
And to you, and thank you to you and your committee for your support. We'll certainly pass on all of the positive comments that you made, and we look forward to being with you again next year.
Thank you. Look forward to it.
Thank you.
Take care.
Thanks a lot. Bye.
Bye. Okay, in which case I'd now like to move to agenda item 6, slightly behind again for Derek, who seems to always end up being the one that ends up having to come on late. So I'll now get your attention to page 25 to 40 of the agenda pack and hand over to the presenter, Derek Ward. Morning, Derek, and thank you.
Good morning, Councillor Macy. Good morning, everybody. What I'll propose to do is run through a little bit about the numbers across the county at the moment and the direction of travel, and touch on some of the district numbers first. Talk a little bit about what we put in the update for scrutiny as well, because there's a huge amount of policy and changes at the moment. So just run through that a little bit, and then try and keep a decent amount of time for questions and answers, because it's a very fast moving area, both in terms of the epidemiology, but also in terms of the policy. So really happy to have that conversation with you, if that's okay.
Brilliant. Thank you.
Okay, so the numbers overall, I'll give the description and then I'll talk about the numbers. What we've seen nationally is a peak in November in our national numbers, a downward trend that's quite evident when you look at the national website and you look at the epidemiology, a flattening out, and actually now what we're seeing across at a UK and an England level is an increase in the number of cases in COVID-19 across the country. Now that's very different by area, with predominantly the north of the country continuing either a downward trend or staying flat, but at relatively low levels. The reason for that is that, as Scrutiny will know, the vast majority of the north of the country was already in tier 3 lockdown scenarios before we went into the full month-long lockdown recently. And the two together seem to have had a very significant effect and impact on the rates of COVID in the north of the country. What we're seeing, and again, it's in the newspapers, everybody will be aware of this, is a significant acceleration of cases in London and the south. For Lincolnshire, it's quite an interesting, different, well, not different, it's somewhere in between. We had our peak around the middle of November. Again, these data are available on the government website. We definitely started coming down from third week of November, but we haven't come down as quickly as I would have hoped, and we are, I think, plateauing at around 250 cases per 100,000, which is above the England average at the moment. As of this morning, the England rate is 184, and on the national website, the Lincolnshire rate's about 255. But we tend to bounce around, and we have done for the past week or so. And these are 7-day rolling averages, so they do flatten out some of the daily peaks and troughs that we get. We're around 250, so we are above the England average. I would expect that we'll actually stay around there. I certainly hope that's the case. And the England average will probably increase. So we may end up not coming down particularly much more over the next 2 or 3 weeks before, it's 2 weeks, isn't it, the Christmas bubble situation. But I suspect England will go higher. So overall, we've come down from our peak, but we've not come down as low as I would have liked. Whether we see a further downward trend, we'll literally have to just wait and see. Lots of volatility at a district level. I think probably last time I was at Scrutiny, we were talking about East Lindsey having very high rates. East Lindsey have now come down very significantly, and their rates are in the region of 150 to 170, so come down an awful lot from the peak. But Boston and Lincoln continue to be key areas for us, who unfortunately continue to see relatively high rates. A lot of that excess between what the England rate is and we're seeing in Boston and Lincoln, we know where it is, and it tends to be in outbreak scenarios in constrained environments. So that might be a number of care home outbreaks, it might be prison-based outbreaks, it may be some of the hospital based cases that you were just talking about with Andrew and Simon previously. All of those outbreaks drive the numbers in those two areas. We work very closely in terms of dealing with outbreaks in those settings, and we tend to get onto them quite quickly, but the problem obviously is we only find out about an outbreak after it's happened, rather than doing what we would normally do with an infectious disease, taking detailed contact data ourselves and histories and working our way back to try to predict where outbreaks might happen and intervene earlier. And again, I think we've talked about that previously. So I think a downward trend, but a bumpy downward trend, flattening out in Lincolnshire at the moment, but we're not seeing an uptick yet. but we have tended to follow the England average right the way through the pandemic, albeit with a week or two's delay. So whether we will start to see an uptick in a week or two, we'll have to wait and see. Clearly, the impact of the changes over Christmas will have an impact, and we will start to see that, in my professional view, in the first couple of weeks of January, if not before. So that's the numbers. Shall I pause there and take any questions on the numbers, Councillor Macy, and then go on to the policy side? Would that be helpful?
No, I think if we carry on, it will just save you a bit of time, I think, in the long run as well. So thank you. Right, you are. Okay, so the paper that we've put together and put to scrutiny talks about the overall COVID-19 winter plan, which is a very good document, worth a read, I would suggest, as it describes the government's overall strategy. 3 key programmes really within that. The vaccination programme, which I'm not going to cover here because it is an NHS-led programme. Happy to try and answer questions, but it is one for NHS England, CCG and others to talk about rather than me. Again, treatment, again, mostly NHS-based, but the testing programme I will cover in detail, or in some level of detail anyway. And it also then talks about they're the way that we get out of this, the science that will help, but also the tiering approach in England is seen to be a key non-pharmaceutical intervention that will keep the numbers down or bring them down if they are high. I'm not particularly going to talk about tiering because I think everybody on scrutiny will understand that. So talking about the testing programme, the way that I would describe this is as in a Russian doll approach. There is a national programme of testing, as we've talked about before, where we have our testing sites, and anybody who's got symptoms, no matter how mild, should isolate themselves, go onto the government website, book themselves a test. They might go into the showground, they might go to one of our mobile testing units across the county. They may go into a local testing unit, like at the university, that you can walk to and get your test there. So that's the national approach. Now, regionally and locally, we have a local approach, which is where we're starting to roll out lateral flow tests, and our local approach covers broadly four key strands. One is to target specific communities or geographical areas where we think there is sustained community transmission. The second is to target what we call high consequence settings. So that might be children's care home, for example, where we would want to very quickly test everybody there to see who might have COVID, rather than wait for the 24, 48-hour turnaround that we would get from the normal testing programme. The third area is when we have a significant outbreak. Again, lateral flow tests will help us to very quickly test a lot of people. Within half an hour, we will get a positive or a negative from that, and then we can follow that up using the normal testing programme to confirm. And the fourth area is to help our domiciliary care providers to make sure that they are testing properly with lateral flow tests, which is part of the national programme. To help them make sure that we're getting true positives and we're not missing positives. So that's the local approach. And very recently, we've been talking to government about what else we could do, and we're in conversations with government on that about an enhanced community-based testing programme. But we'll see where that lands, and happy to come back to scrutiny and discuss that in more detail once we've got it. So I think in terms of the policy at a high level and what we've included in the paper, that's probably covered the key points I wanted to make. I'm sure members will have lots of questions about the detail and maybe some of the announcements yesterday, for example, testing in schools. Happy to take those questions and try and answer them as much as I can. Thank you. That's much appreciated, Derek. We'll start with Councillor Whittington first, please.
Thanks, Mr. Chairman, and good morning, Derek, and thanks for the update. One thing I do find sort of really frustrating, and I guess you must find it frustrating as well, is that, you know, in Lincolnshire we're still above the national average. you know, and because to my simple brain, we should be in a really good position, Lincolnshire, to actually control the infection because of the rural nature of the county. And I'm just wondering, you know, because I suspect at some point in the future there'll probably be a review or a national investigation into how things happen and lessons we can be learned. Is it, you know, I know it's anecdotal at the moment, but is it the case that people in Lincolnshire simply aren't, a significant number of people simply aren't following the rules? Or is there something in the demographic of the people of Lincolnshire in terms of age demographic or obesity or smoking or other sort of public health issues which feed into that, which kind of give us, you know, which is why we are above the national average? That would be my sort of first question around that. And my second one really is in terms of sort of national policy. I mean, I've sort of expressed, I don't know if you heard the earlier debate with Andrew and Simon, but I mean, my personal view, and I know it's the view of Councillor Bruce as well, is that the proposed relaxation of the restrictions over Christmas is just a mind-bogglingly stupid decision. But that's just, you know, because I think potentially we could end up by having a real, you know, we could pay the price in January, and there'd be innocent people who'd be potentially paying the ultimate price of losing their lives. And I'm just wondering, in terms of policy, if there is a mechanism for, you know, for the people like yourself as Director of Public Health to feed back to some of the politicians and policymakers, you know, in London, you know, the concerns the local people, local politicians have, local residents have about, you know, this, because, you know, I'm not an expert, but every single time we seem to have eased restrictions, we seem then to have had a knock-on effect. You know, at some point in the future, it comes back, and I'm just thinking that, yeah, I know, and I take it about the hospitality industry, and I know that it's having a massive impact on the hospitality industry and other businesses, and it's a terrible situation, and it's probably the most disruptive time at the moment, potentially since the Second World War, in terms of the impact this is having on people's lives. But I'm just wondering, you know, what ability you have to sort of feed back to government and to the policymakers, you know, some of the concerns the sort of local people on the ground have. So those are my sort of questions. Thanks, Derek, and thanks, Mr. Chairman.
Thanks, Councillor Whittington. I think two really good questions, and they actually are fundamentally linked together. So if I talk about, I'll take the second one first in terms of Christmas. I think what we know, and this is where it ties to the first question, is that the Tier 1 restrictions that Lincolnshire were in and lots of sort of southern parts of the country were in before the lockdown did not keep R below 1, did not constrain onward transmission of COVID. And that is why we saw an uptick, an increase, a very significant increase in some parts of our county over the past month or so. So I would expect, and obviously I'll speak as your Director of Public Health, not in terms of the economy, because I completely understand other people will have different drivers, but from my perspective, my job is to do everything I can to keep the people of Lincolnshire safe. And there will be a significant increase in infection across the country and across Lincolnshire over January because of the changes over Christmas. That is national policy. We feed that back through the Chief Medical Officer calls, and of course the Chief Medical Officer understands that as well. I think just coming back to the last part of Andrew's comments I heard when I came onto the call, I think this is one where local politicians can very much feed their views back to central politicians as well, because there is clearly a balance to be struck. But from my perspective, it's about protecting the people of Lincolnshire from COVID-19, and I think the Christmas bubbles, the Christmas tiering in effect, will have a very significant impact, and we will see at the beginning of January in general numbers, and then it will flow through into the hospital setting in the middle towards the end of January, and unfortunately I think it will flow into our mortality figures towards the end of January and into February, at a time when the NHS is always traditionally very stretched because of other winter issues. So yeah, that's my view on the Christmas thing. I think in terms of the what we've experienced over the past month, 6 weeks, in terms of our rates going up, Boston and Lincoln being on the national profile because they stood out, and the fact that we are still above the England average, I think is first thing to say is the people of Lincolnshire, I think, have generally stuck by the rules really, really well right the way through. And if you look at our data up until most recently, we have been below the rest of the country generally, and from a Midlands and an East Midlands perspective, we've had some of the lowest rates right the way through the pandemic. So I think all of that's positive. We shouldn't just focus on the last 6 weeks. However, the last 6 weeks has seen something quite different. I think partly that's down to the fact that we're in tier 1 when we went into lockdown, as I've just described. I think we are experiencing a lot of setting-based outbreaks. Some of that is we have an older population, we have more care homes, and that's part of the challenge, even though the care homes have done a fantastic job. But we'll basically continue to work with them and see how it goes. But I don't think we can put our finger and say it's because the people of Lincolnshire have decided not to stick by the rules. I think it'll be far more complicated than that when we do have that national review.
Thank you. Thanks, Derek. Now move on to Councillor Renshaw, please.
Thank you, Chairman, and good morning, Derek, and thanks very much for your report. It's well received because it does put into perspective what's going on from your point of view in the local and the national scene, and we are only lay people, most of us on this committee, so it is helpful. Reference you've detailed the government's objectives below, and do you not accept, Derek, that without bringing the R rate down, where the bullet points 2 and 3 will take disproportionately longer to achieve? I mean, my view is that my grandchildren will be paying off the cost of this plague, and until the majority of global spread, the global spread will continue to wreak havoc on those countries that are less resilient than the UK, and will exacerbate poverty even further. And that poverty in itself does come back to haunt us, because it does make cross-infection cross continents. I mean, you don't want 2 or 3 aircraft, and we've got it all flying around the world. Every day, I mean, I've raised the point at the question I asked at full council, but every day I see evidence of many selfish people determined not to social distance. They do not realise the debilitating and life-changing after effects of contracting COVID. I've got a relative who works in health, and he contracted the virus. He's now recovering, but it really is life-changing effects of the debilitating effects of having that are going to be with him. You know, and there's no time scale when he will be fully recovered. People do not realise that, and I think the Lincolnshire Resilience Forum, which I know you are a member of, trying to get this message across on a variety of media platforms. But in my view, it's got to be that getting the message has got to be even stronger than what we've had in the past, because it's not getting across. I mean, we've put over reliance on social media, but when you try to analyse what social media does, all it is legitimising and popularising social tit-tat, and that's not what we're about. It's a serious message, and I cannot stress enough my feelings on that it needs to be strengthened. The message needs to be strengthened. Need to give people space in the streets, and you're faced with an impossible task, but that's got to be the strength, you know, and that will ensure that the R rate does come down in the long term. and you're not having to give statistics in future Health Scrutiny Committee meetings that's going to be the horror story. So thank you very much for your report, Derek. I'm sure you'll answer correctly well.
Thanks, Councillor Renshaw. I think in terms of the messaging, you're absolutely right, and I'd ask every member of Scrutiny, every local politician and everybody listening or on this call to remember and to push the hands, face, space message. So that's washing your hands properly for 20 seconds whenever you change in locations. Make sure you've got a face covering when you're in an enclosed space outside your own home. And actually, by all means, if you feel more comfortable wearing a face covering, walking down a busy street, then do so. Bear in mind, though, that the face covering protects others from you if you've got the disease, but you're not showing symptoms. It doesn't protect you. So, important point about that one. And that comes on to your point, Councillor Renshaw, about the space. I've been an absolute advocate for 2 metres plus, no matter where you are. If somebody isn't in your household group, stay 2 metres away from them or more, and you will absolutely minimise, you can't get rid of, but you'll minimise your risk. That's what we need to do. I think the other thing to say about messaging is whether the government changes its approach to Christmas bubbles or not, just because you can do something doesn't mean you should. And I think that's another thing that everybody in Lincolnshire needs to consider. Just because you can form a bubble with 2 other households doesn't mean you should, especially if you're in a higher risk group or you've got concerns. I think this Christmas, from my perspective, we should treat very differently from a normal Christmas in lots of ways. And so I'd make that point. I think your first point about global travel and about the medium and long term impacts of COVID, I think from a COVID perspective, you've got the short term impact of you've caught it and will you recover over a 14-day period. There is a syndrome that we're now starting to understand that is generally called long COVID, that can then have long-term impacts on people's health and well-being. So this is not just an immediate disease, this is a disease that can, and it seems does, have for some people longer-term impacts. And then, of course, the impact of COVID and lockdown on the economy, on children, young people's education, which is why I'm a real advocate for keeping schools open, will be felt for generations. And we need to deal with that, and we need to build into not just our health and social care systems, but our wider approach to society, how we're going to tackle that. I think the shining light, the positive about all of this, though, is that we will find, and we are finding, and we have ways to deal with COVID as a specific disease. So I do not see COVID-19 being a specific disease we will need to worry about in the same way we are at the moment next year, at this point next year. We will, as you know, we're rolling out a vaccine. We're going to get new vaccines coming on board. We've already got much better treatments in the acute sector. And as we get more and more people vaccinated, the disease will find it harder and harder to get hold in a population. So I don't think COVID-19 in the short form or even long COVID will have a massive impact on the population long term. But I do accept and I do agree that the year that we've had will have a long-term impact on society, and we need to be mindful of that as we go into 2021 and onwards.
Thank you very much.
Thank you, Councillor Renshaw. Thank you, Derek. Councillor Mrs. White.
Thank you. Our lives have been restricted partly to protect the vulnerable, including the elderly. I'd just like to say that I've stayed in a hotel in Lincolnshire in July, and I've gone swimming where measures have been put in place, our names have been taken, and we've not been contacted. The last time there was a wave in Lincolnshire, the care homes seem to do better than they're doing at the moment. The 3 people I know who've died recently, over 78, one was caught COVID in hospital, the other 2 in care homes. So I'm wondering, is there a particular reason why I know there's been large incidents in care homes, especially in East Lindsey? Thank you.
Thanks, Councillor White. As you said, we know that with both the hospital and the care home settings, outbreaks are a real challenge. In the hospital setting, I'm sure Andrew talked about nosocomial transmission, so that's when people who are in hospital who haven't got COVID catch it in the hospital setting. That's a real issue for us in Lincolnshire, and one that I know Andrew and the NHS are trying to get on top of, but that's clearly going to have an impact. We do test people before they're discharged into care homes, so we know their status. We also have a programme, a national programme of testing in care homes, which is weekly for staff and every 28 days for residents. The introduction of lateral flow tests is going to increase that, but there are risks with that. I think I heard some conversation about that just when I came on with Andrew. I think the why are we seeing those outbreaks in care homes is the bit of the jigsaw I can't answer. If it was tuberculosis, or if it was a winter vomiting virus or something else, we would take detailed histories of everybody who was positive, and we would work backwards to understand where they'd been, who they'd been in contact with. We would then go and test those people who they'd been in contact with to see if they were positive, even if they weren't showing symptoms. And through that process, we start to understand where the key sites of what the key behaviours are that are driving particular outbreaks. Unfortunately, that's not something we can do because that is covered by the National Test and Trace programme, and the National Trace programme don't go to that level of detail. They don't take detailed histories. We are in conversations, and I've been pushing this for a number of months, about being able to take on some of that work. Clearly, it's a massive resource. At the moment, over the past 7 days, we are seeing in the region of 2,000 cases in the county. And if every case has 2 to 3 close contacts, you're talking about 6,000, 8,000 people you'd need to follow up, and we just don't have that resource unless we got some of the National Trace programme resource redeployed to us. One of the things I didn't include in the update, I did include in the update, but I haven't talked about in detail, is the new NHS Test and Trace business plan. And in that, there is some detail about local first. I await with real interest to see what that means, because to do what we need to do, Councillor, like you flagged up, we're going to need those resources, and we're going to need to backward contact trace to really understand where people are catching it, what the behaviours are, and then intervene. And we'll be able to do that if we get that resource. But until that, we are to some extent, if not a large extent, in the hands of the National Trace programme.
Thank you. I'd just like to say I know that not only you, but several people have been putting pressure on the government to have more local facilities, and it must be really frustrating. Thank you.
Thank you, Councillor White. I have 2 more speakers and I'm going to close down the debate. So first of all, it's Councillor Woodliff, please.
Thank you, Chairman. Can you hear me?
Yes, we can hear you.
Oh, thank you. Thank you very much. Sorry about that. Good morning, Mr. Ward. What have we got to learn from other countries around the world? And I'm thinking particularly about Taiwan. Population 23 million. In total, according to the BBC, I'm looking at now, 742 cases, 611 have recovered, and have been 7 deaths. 7 deaths. In the UK, 50,000 deaths. Now, what have we got to learn from other countries around the world?
Thank you, Councillor Woodliff. The key point there, I think, is that Taiwan and some other countries around the globe, not many, certainly not many that have managed to do it over every wave, have had really aggressive test, trace and isolate models at a very local level. So it comes back, I think, to what Councillor White and I were talking about just before. With any infectious disease, normally what we do is when we get one case, we go in fast and we go in hard, and we do all of that backward contact tracing to understand where did this person get it from, whether they brought it in from abroad or whether they've caught it from a different part of the county or the country. We then do all of that outward contact tracing. We test all of those people and we isolate them and we support them to stay isolated. That is my understanding of how Taiwan does it, and has done it. And South Korea was also held up as an exemplar of best practice, but I think they've struggled more recently. A lot of this is tied up into also the nature of their societies. So, it's not a simple lift and shift, because every country has different cultures and approaches, laws, legislations, and political views. So, it's not a simple pick up. But I think your point about what can we learn, you're absolutely right. My view is that we know how to do this, but for whatever reason, we have a model that I would say the national testing programme is excellent. We have some of the best testing models in the world in terms of capacity. The PCR test is the gold standard, and that's what you would get at the showground or in the local testing unit, mobile testing site, or if you order a home testing kit. I think there's other bits of our model that aren't world beating, that could have been done better, and that we should have learned from other places. So I think it is a bit of a mixed model. But I'm going to sound like a broken record. For me, and we can only do this when the numbers are low, it's about that backward history taking, testing and isolating people. When our numbers are low, that's how you keep them low. But when they're at a certain point, it just becomes, you just don't have the capacity to do it. And at the moment, our figures are too high. As I said, I'll wait with interest to see what the National Trace Business Plan says is the role of local places in this in the future.
Thank you. Thank you, Mr. Ward. Mr. Chairman, may I just carry on shortly?
Yeah, as long as it's shortly, that's absolutely fine.
It's fine. Thank you very much. I'm looking at the report from the BBC actually on my PC, and it says that Taiwan's impressive success battling the coronavirus has been largely attributed to early and strict border controls, a ban on foreign visitors, and mandatory quarantine for all Taiwanese returning home, amongst other things. I mean, it's a public health thing, really, isn't it? I mean, the NHS is at the forefront of this, but it is a public health matter, and public health actually rests with councils and with the government itself. I don't think the government has handled this very well, but that's a personal opinion. Do you have any comments, Mr. Ward, on that?
I think that description fits very much with what we've just talked about. It's about where a case is coming from, and as I introduced in my comments, if the cases are coming from abroad, if there's a very strict quarantine period and testing regime, then that's how you stop what's called seeding of the disease from other countries. And equally, other countries, if people from our country go abroad, same way around. That's how you stop seeding it in lots of places. But you have to marry that with very rigorous control of the disease within the country.
Yeah.
And that's where the isolation and the test, trace and isolation program fits. If you get those two bits right, and you go in early on that, you can keep the numbers down, and that means you can put the resource in to keep people isolated and keep the disease away from others. Once you get to a certain point, it starts to get that exponential growth that gets away from you. And that unfortunately is what we've seen. And to be fair, the vast majority of European and other countries have seen the same.
Thank you very much indeed for your very comprehensive reply. And thank you, Chairman, for allowing me to speak again. Thank you.
Thank you, Councillor Woodley. I have one final speaker, and that is Councillor Kendrick, please.
Thank you very much, Mr. Chairman. Just following on from the last point, I understand that Italy was particularly hard hit, and the part of Italy that was hard hit was had very strong links with China to do with, I think, with the fashion industry and so on, and that seems to be where it spread. But my question is, I was just wondering about the policy change, Derek. I seem to recall at the start of the first wave that I think it was Jenny Harris, Deputy Public Health, I think she is, I can't remember the correct title, was sceptical about mask wearing, and then obviously there was a policy change. I was just wondering what drove that, and I'm sorry because I missed part of the discussion due to sort of being losing connection, but I was also wondering, lockdown obviously is the solution. If we lock down the country permanently, we wouldn't have a problem in that respect, but it's obviously this terrible issue of balancing between total lockdown, and then whenever you lift a lockdown, and other countries have done the same. I think Germany now is having to go back into a lockdown. You get a rise in infections. It seems to be an insoluble problem. I don't know if there's any way out of it, because obviously we can't have a permanent lockdown because our economy will totally crash, and we'll be in a terrible situation, even worse than we are now. So I just wonder if Derek's got any thoughts on those two rather random comments. Thank you.
Thanks, Councillor Kenrick. Jenny Harries is Deputy Chief Medical Officer, so she reports to Chris Whitty along with John Van Tam, who's the other Deputy CMO.
Yeah.
I think the scepticism about, it's not mask wearing, it was face covering, and it's important to make that distinction. In the NHS and the infection prevention control, we would wear appropriate masks to the right level that would stop us catching the disease, because it would stop the virus getting through. Face covering is about reducing the risk, if you've got the virus, of it you reduce the amount of virus getting through, and therefore it reduces the overall risk. The general concern at the beginning was that people will use a face covering and think they're wearing a mask, and therefore they're magically immune, and they're not. And that was why I think Jenny and Chris and others were concerned about it, and I shared those concerns at the beginning. We just didn't have the evidence. Now, as it's transpired, there was a general view that no, we should use face coverings. Having said that, the rates we've got now with our current wave are much higher than they were with the first wave when we didn't have face coverings. So take from that what you will about the efficacy. That's not me saying don't wear a face covering. You must wear a face covering if you are outside, if you're in an enclosed public space. Don't get me wrong, but I'm just saying that's probably where that came from. In terms of the lockdown, it's not as hopeless, I think, as you maybe thought, Councillor Kendrick, because we have the vaccine now. So, you know, if it were down to me, I would have everybody in a lockdown for the next 3 months while we went round and vaccinated all of our 50-year-olds and above, including care home workers and NHS staff. That would have a massive, potentially would get rid of 99% of our COVID deaths if we could vaccinate everybody 50 and over. And economists will argue about the pros and cons of that. But for me, that hit on over 3 months, because we'd probably do it over 3 months. If we were in lockdown, we would definitely get the rates down while we were doing it. We would vaccinate everybody, and we would come out of a lockdown into what would be almost like a normal reality. And we would have January, February, March, maybe a bit of April, where we would have to make sure, as a society, we were covering all of those businesses that were taking the hit, as we did with lockdown 1. The one change from lockdown 1 for me in this model would be you'd keep schools open, because I think the impact on children and young people, not necessarily higher and further education, but children and young people, of closing for that period would be far worse than them carrying on. So that would be, you know, from a public health professional perspective, that would be ideal, because we now have a vaccine. We can vaccinate everybody. Key message, if anybody gets offered the vaccine, please take it. We have some of probably the best safety regimes and regulations in the world. So the MHRA and the Joint Committee on Vaccination and Immunisation have both said this is a safe vaccine, and we're going to get some more. So that would be my approach to lockdown.
Thanks very much. Thank you.
Thank you, Derek. We've got one more speaker. I know I closed down the debate, but Councillor Rosemary Cadbury-Brown came in very last moment, so I shall allow her to ask a very short question.
I'm trying to unmute, Mr. Chairman. Can you hear me?
We can hear you. Thank you. Yes.
Oh, right. Fine. Yes. This is a quick question. When children come out of school, now when children are in school, I'm quite sure they try to keep the distances because of teachers. Is there anything at all that you can send someone into schools other than the teachers and explain the severity of the situation we're in? Because I know when they come out of school, they start locking arms, walking along in 4s or 6s, and they do not distance. And they're young people, they just need someone to really ram it home. There's no no way I don't think that you can get the schools to do it, because they're conforming with the rules as far as they're concerned. But when the children get out, and if you see them come out of school, which I often do, there's just no hope. They just don't distance. They're hugging and kissing each other, and behaving like that. The boys are playing, you know, locking arms and kicking balls and all kinds of things. It was just a thought. I mean, at one time you could give them various forms of, years ago you made them write lines, but in this day and age you don't. So there has to be something that the teachers or you can administer to tell them they've got to do it. Thank you very much.
Thanks, Councillor Cayley-Brown. I think a few things with children. Firstly, clearly they shouldn't be doing, as you described, outside of a school environment. That's clear in the guidance, and is certainly something that all of our schools, I'm sure an awful lot of parents are pushing. But we need to keep pushing that message. Don't disagree with that. What I would say is that all of the evidence suggests that children are not driving this pandemic. If you look at the rates of cases in school-age children, 4 to 16-year-olds across the county, it's about 180 per 100,000. Our overall rate, 255 per 100,000. So in that age band, we have lower levels of disease. We know from emerging evidence that children and young people are less likely to have the disease, as evidenced by those data, are less likely to pass it on to others, and are less likely to have severe disease if they do catch it. So I think there's always a balance, and of course children are children, so we need to recognise that. There's always a balance, isn't there? And I think what we saw with the first lockdown, when children and young people weren't in school, real significant impacts on their well-being in terms of their relationships with their friends. In school, they will be part of a bubble. They will have a friendship group, and that is accounted for in the policy that we have. So often, some of these walking back home groups will be their friendship groups who they are close mixing with in the school setting. So to some extent, that will offset the risk. But ultimately, they are less likely to catch it, less likely to give it to other people. And my view is we need to keep schools open.
Thank you, Derek. That's very useful. Okay, in which case I'm now going to close the debate down, and I'm going to move to the proposal. My proposal is that we note the contents of the report and we receive a further update at a later meeting. Do I have a seconder, please?
I'm happy to second that and thank Derek for his absolute frankness, and wonder if we can't actually put him in charge of national policy, how we address this, but that's perhaps a bit too far. No, he said no under any circumstances. I'll second that, Chairman, and I thank him sincerely for a very, very frank and open.
Thank you. In which case, is there any dissent on that proposal? Thank you. I'll take it as not. So that's carried. And I'd just like to thank Derek very much for his time once again today. A very useful debate. Sorry, my brain's gone now. I think it's all talk about COVID. In which case, I'd like to wish everyone a very Merry Christmas and hopefully a better start to the new year. So thank you all very much for your attendance today, and speak to you soon. Thank you. Take care.
Bye. All take care.
Thank you, Chairman. Bye.
Thank you, Chair. Good wishes.
Thank you all.
Thank you very much.
Bye.
Merry Christmas, everybody.
Merry Christmas.
Bye-bye.
Merry Christmas.
Take